Dear friends, dear colleagues, hi again. In this part of the presentations, I will try to do my best to defend shockwave lithotripsy in the management of large stones in pediatric population, to discuss the issue with one of my really brother in stone, Mohammed Al Omar from Saudi Arabia, from Riyadh. He's an expert in PNL, and it's not so easy. But if the case were in adults, it could be a little problem. But when it comes to pediatric cases, I think there is some chance for me to go further and to defend shockwave lithotripsy. Regarding the ultimate of kidney stone management, we need to have maximal stone clearance with minimal morbidity. But when it comes to the large stones, particularly in kids, we need to be highly careful in order to remove all the stones from the growing kidney, small kidney of the pediatric cases, not to cause severe problems after the procedure. Management options are here, and today we discuss about two different modalities. There are some facts regarding the management of stones. We know large stones. Majority of simple renal calculi can be treated satisfactorily with shockwave lithotripsy. It's an effective and the only non-invasive treatment modality when it comes to pediatric patients. It's more important. Various stone and patient-related factors could affect the outcomes of the procedure, and among them, stone size and to some extent, stone location is very important. Large and complex stones could be treated very well, and we need to remove all fragments, if possible, from the kidney. When it comes to the published data, these slides are a little bit old, but still they keep their importance and value, published by Lingemann years ago. Depending on stone size, shockwave lithotripsy will be highly successful for stones up to 2 centimeters in adults, particularly as you see here. But when the stone size comes over 2 centimeters, then the stone-free rates will come really down. When it comes to second stones, here you see shockwave lithotripsy will have around 50% stone-free rates, but PNL and in combined manner, nowadays endoscopic combined procedure will provide really higher and higher stone-free rates after the procedure. About the procedure per patient, shockwave lithotripsy, retreatment rates will be higher in adults in treating the larger stones. These are the data coming from adults, because shockwave lithotripsy in pediatric cases, to treat them, when you go through the literature, you will find really limited data published so far. What are the limitations? Multiple treatment sessions and auxiliary will be needed. Auxiliary procedures will be needed. Significant postoperative complications, including street formation, colic attacks, sepsis, and hematoma formation could be anticipated. But treating large stones in children with shockwave lithotripsy may have some advantages when we compare the modality with adults. With the advent of new type of lithotripsy with great efficacy, the results of shockwave lithotripsy monotherapy for larger stones has changed the outcomes remarkably in pediatric cases. Pediatric population seems to be particularly well suited for shockwave lithotripsy monotherapy for larger stones. What are the underlying factors? Limited stone burden, because diagnosis is early, better shockwave transmission due to the smaller body habitus, no fat issue, and a more compliant ureter for the passage of the stone fragments. When we go through the literature to evaluate the outcomes for shockwave lithotripsy, here in this study, Dr. El Nahas and his co-workers did evaluate the factors affecting the outcomes of shockwave lithotripsy for pediatric renal calculi, focusing on stone location and stone size, prognostic factors, and in the end, they were able to tell that shockwave lithotripsy should be recommended for renal pelvis stones up to around 2.5 centimeters, depending on their data. Again, other studies, here you see in the literature, Orsola and its co-workers, an old study, but they performed shockwave lithotripsy in Stackhorn stones in 14 children, and the outcomes, stone-free rates around 74%. Notman and its co-workers in very young children did show higher success rates with limited complications, with no major complications in these young children. Schumann and his co-workers, again, they treat monotherapy with shock wave monotherapy, stones in children up to 2.5 centimeter, 24 children, and you see the age, stone size averages 3 centimeter, and the overall stone free rate was around 84%. Acceptable for children. That means could be in the first place to treat the cases, but to evaluate them very well in the beginning of the procedure. Dr. Ater from Pakistan, they evaluated again the stones to be treated up to 3 centimeter in children, and they were able to show that 80% of the cases with the residual stones at the double J stand, but stone clearance will be acceptable in these cases. Al-Busaydi and his co-workers did evaluate the efficiency and safety of this modality, and standard patients, they had fewer major complications and shorter hospital stay, the pediatric cases when treating large calculi in this population. Dr. Renal from Turkey, they evaluated again treatment of pediatric stones with shock wave lithotripsy. They evaluated different approaches, and in the end, for the stones sizing between 1 and 2 centimeter, shock wave lithotripsy did seem no doubt in the first place. But pediatricians, when they refer the cases to the urologist, they seem to prefer shock wave lithotripsy in the first place, whatever the stone size is. This is a systematic review evaluating the imaging modalities in the treatment of pediatric stones, and in the end, the author did quote that shock wave lithotripsy is recommended as the first line treatment modality for stones less than 2 centimeter. That means if the stone is 1.9 centimeter, 8 centimeter, then it will be the first modality to choose. When we go through the guidelines, EAU guidelines, for stones sizing less than 1 centimeter, no question. It's always in the first place. But when we evaluate the relatively larger stones, moderate sized stones, again, you see here, between 1 and 2 centimeter, shock wave lithotripsy in the first place, but for larger stones, maybe PNL could be in the first place. Going through the different guidelines, here the EAU guidelines, and when we evaluate in pediatric cases, in the total renal stones burden less than 2 centimeter, clinicians may offer shock wave lithotripsy or ureteroscopy as the first line. In pediatric patients with a total renal stone burden more than 2 centimeter, both PCNL and shock wave lithotripsy are acceptable treatment options. AUA guidelines recommend that. I don't tell, they tell them. So, AUA guidelines here, shock wave lithotripsy have a very limited role in patients with complex renal calculi, but successful in pediatric cases or in low volume second calculi in normal collecting system. About the UK, when we go through the guidelines, again, for stones sizing less than 2 centimeter, again, they recommend shock wave lithotripsy as acceptable as with PNL in the management of large and complex stones. To conclude, again, my dear friend Mohammed, he will come here and defend PNL. I may say that shock wave lithotripsy monotherapy for stone calculi in adults should be reserved for selected cases. Shock wave stone free rates are significantly lower. Published data show that risk of obstruction and the percentage of secondary procedures are really high. Adult patients with low volume second calculi in a normal non-dilated collecting system and pediatric patients may represent good candidates for shock wave lithotripsy monotherapy. Significantly higher stone free rates could be obtained through PCNL. In addition, newer shock wave lithotripsy devices have improved stone free rates, particularly in pediatric cases. If shock wave lithotripsy monotherapy is undertaken, adequate drainage of the treated renal unit should be established prior to the procedure. Thank you so much for your attention.